SystmOne brought out the auto review process that allows you to file and process your results really quickly and easily. But it's not had the uptake that many people thought. And that's because it is a little bit complex to figure out how to do, how to structure, and basically making it work in practice. Well, don't fear. I've got Dave Hindermarsh joining us today to talk about how you can do that in practice. This is feeding off some of the content he's already provided. We're going to show you some of that as well as we tech enhance your primary care and learning. Hello, EGP learners. Welcome to this episode. We're really happy to have Dave join us back again on the channel. And this time we're talking all things TPP. How are you doing there, Dave?
I'm very well. And just to say, from all the EGP learning audience, it's great to have you back. And so sorry to hear about your dad.
Thank you. Appreciate it. So yeah, have been away for a little bit, back to form, hopefully, though, and getting back into things. And I guess one of the things I really wanted to cover for the EGP learners out there, particularly those of you who use SystmOne, is how to use the auto review function. Because this is something that came out in the past few months. And I know I've wanted to even figure out how to use, but I've got to admit, even I found it complex. It's really tricky to do. So it's been great that people like David and others have been having a look at this and trying to figure it out. And in this episode, we're going to cover basically most of what you need to know. And if you can't find it from this episode, then definitely check out the stuff that David's already got, and we'll have more of in the future covering this because it is tricky, but we're going to lead you through absolutely everything you need to know about that. I guess the first question though, David, just tell us your perspective of what the auto review function is and what it does and stuff.
So I love the auto review function. I sort of saw that TPP pushed it out. And for me, it's all about reducing your decisions. So, I'll often get 20, 30, 40 blood results, maybe more if I've had a couple of days off. And I find that there's a chunk of them that I'm not using my brain. And I'm just going like normal, 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 as I'm sure many GPs are. And I'm conscious as well that this adds unnecessary decisions, though even tiny ones, to your day. BMA are trying to push us down in terms of patient contacts. And a lot of that is down to decision fatigue. It's been well documented in our ED colleagues about that there's only a set number that we can have. And I thought, well, hang on a second, like if we can hit a button and it will wipe out even just a small number of pathology links, then surely it's got to be a good thing.
Yeah. And I think, having seen this in action a few times, both with TPP and from other people that have been doing some cool stuff, it can have an impact in the volume of workload that you've got to deal with. And then there's even more that you can potentially then start dipping your toe into in terms of how you can automate the process in the back end to make some of that not only patient time saving, but also more importantly, practice time saving as well. And we're going to try and cover some of that for you today. I guess one of the things, and I'm going to answer this question now because it's one that keeps coming up, it is why have TPP done this in such a slow way? And I think that's something that people need to be aware of. So this technically has been around for over a year, but it's been only full release a few months back. I think part of that is because there is this real complexity that comes about that every single area has a different lab, and because they have different labs, they have different results, and because they have different results, you can't have a one size fits all. There is some work you need to do to make this personalized to your geographical and practice population area because of the fact that you have not only different results, and we're going to get into this as well, different perspectives of how to handle those results within your practice as well. So just wanted to mention that. And that's why it's taken a little bit longer than planned to get this stuff out to you, and also why TPP have had some challenges with it as well. Any thoughts on that, David?
Yeah, and I think we were chatting about before we hit record that what Ardens did a very nice webinar about this, and they identified that the sweet spot for this is probably at PCN level, because if you think about your PCN, you generally only feed into one or two hospitals for your results. I've noticed as well that even to get I'm only in the very early stages of this, and this has taken a lot of work. But if you're thinking, well, hang on a second, if I'm doing this work for the PCN rather than just the practice, then actually there's some economy of effort from that point, and working with each other. And it's clear politically that's the way we're sort of moving forward. So anything you can quickly add in just to carry good favor is not a bad thing. I'm also involved in our local federation, sort of trying to optimize the digital aspect. So having an awareness of this, even though I may need to tweak it. And I'll explain how some of the rules have got like the initials of the hospital, just thinking if I do want to transpose this over, that I'm not going to cause any upset or misfile something unnecessarily.
And I think just to enhance that point, if you're looking for a project for your digital transformation leads within your PCNs to look at, or if you've got, a willing GP or clinician that really wants to get their teeth into it, this is a great project for them to look at, because this is one that potentially will save time again. Okay, well, we're going to get into it. We're going to show you what this looks like. So let me bring this on for you, David, and then you can walk us through what this is and how this relates to the auto review. So take it away.
So this is the auto review in action. I had about 8 or 9 rules sort of running at this point. I've blurred out all the patient results. If anyone watched my first video, a very, very kind GP out there made me realize that I left a patient result up. So deep apologies for that. But with this, you've got your pathology links. I've been nice. I've done it for the whole practice. And the second button says on the left, so just as the sort of the toolbar says apply auto review rules. If you click that button, it will say, do you want to run them for this? And you hit yes. And then it takes a bit of time. So I think actually this is probably a bit sped up. But it took me about sort of pushing 2 minutes. But I think, well, and you can't use SystmOne whilst you're doing it. It just sort of locks it up. So I basically, have a chat with someone else, you can still answer your email. So it just gives you that bit of headspace to do something else with it. What's really nice as well, if you're worried that you've misfiled something, or you just, as with our experience, you're just trying to trust it, is that 2 things happen. You'll get a pop-up box at the end saying that auto-applied rules applied for these patients. So you'll have like the patients themselves, what results have been auto-filed, and then it'll be white, clear, and it'll tick it off. And then if you scroll down, it will have a pink, so sort of like a ready color that says they've not worked for these results. And when you close that, before you hit refresh, it will just gray out all of the results that it's taken out for you. So that if you're unsure, or if you recognize a patient and you think, no, I should really look at that, it gives you an awareness. So it's not that it just wipes it out completely.
Mm-hmm.
And it just gives you that bit of a safety blanket, because I think that's where people are struggling, is that it's such a new and quite alien concept that you're thinking, oh, I don't want to miss anything, quite understandably. And I think that's where people have sort of paused and struggled with from that point. So I'm hoping as the taskbar sort of finishes up that it will sort of pop up initially, and also gives you a massive, I get a little dopamine hit, because suddenly your numbers go from like 40 down to 45. So you can see here, the white box is where it's all worked. The red is where it's not worked. Okay, so you can go individually into those patients and double check those there from that way. So that's it. Happy days.
Yep, and we can see that numbers shot down at the bottom as a result of it. And I guess the key thing that you see with this is then obviously how much this clears out per practice, and it is going to be different per practice based on those rules that you set. Now, I know one of the challenges I've had with this is the fact that I found it really complicated to understand the guides. Tell us about that, David.
Yeah. I love TPP. They've been very, very kind to me, and they put one of my videos up front. But the guide, even though I love this stuff, was very hard to get my head around. So shall I go through it a simple Dave way from that way? So the easiest way that I think about it is that you've got to think about this in 2 separate parts: the investigation itself, and then the result itself. And you've almost got to set 2 sets of rules. With the investigation, it comes from the labs differently, hence going back to our previous comment why TPP haven't done it. And they're either going to be read coded or a text, or sort of like a free text result. You can tell it. The simplest way of trying to suss it out is that when you're going through your pathology list, right click on it and print it out, and it will say in the top left hand box what it is. So it might be, so for example, I've got one in front of me here. So our liver function tests are read coded with capital X 77WP. So that shows that you must do that one. You've then got the second part, which is the results themselves. And then you've got even more complexity with that, because you're thinking, right, do I care about one particular result? So for example, ALT comes back as a single numeric. So you can set it as one of these exists, and you can highlight that read coded numeric. And if it's less than your normal range of your labs, it's gone. The complexity comes in with when you want, for example, going back to liver function tests, is that you need everything to be normal from that way. So you need to code every single result in a range of values. But also what they trick into, or they've hidden away, and it's down to the lab results coming in, is that actually there's almost an empty investigation for, normally it's the test again that's repeated. And there's an option that you can add a rule that says like liver function tests can be ignored if present and empty. And then there's a comments box as well. So it's just adding that extra complexity. And I've seen from some of the Facebook groups that we're on that's where people have stuck of saying like, how can I ignore this comment? And there are additional rules that you set up to get rid of them from that way. So yeah, it's, once you've got your head around it, you're like, yeah, that's fine. I spend countless times, you're on the right track with in terms of the investigation. When you've got your list of pathology links, you can right click on it and hit preview auto review rules. If nothing pops up, you've got the wrong either read code or value. If something pops up that says like, I've got a rule there, brilliant. And then you can hit a drop down box. If it's red, it's not worked. So you need to then go into your investigation rules, or if it's green, happy days. And the number of, I think my fellow partners must think I'm absolutely insane, because the number of commutations and tweaks that I've had to do, and then I suddenly scream out, yes, got it, when it finally works. So you do need, I'm sort of looking at this, you do need time to go through this and sort of time to discuss as a team about what you're comfortable to do. And I think that's where TPP have held off at, because everyone's levels, individual practices are going to be different.
And I think to give you a guide of what you can do to fix those challenges. So one option is absolutely looking at Ardens, who have done some work around this, and they have set out some rules that you can import if you're subscribed to Ardens into your practice and then start using. Now, important to recognize, they are set at the safest possible limits, and they've had to counter for the fact that these are potentially used across the country, across different labs and stuff, so they may not be 100% accurate for your particular area, which is why you will still need to do some work rather than just click import and go. I'm pretty sure you found that as well, haven't you, David?
Yeah, and they were very clear on their webinar about, like, this is why they've done it, and I don't blame them for it. It's really easy if you're subscribed to Ardens. So you've got your actual auto review set, and you effectively, there's a drop down bar that says scope, and you drop it down, and if you're subscribed to Ardens, it will say Ardens Limited, and you can click on there, and their rules will pop up for you, ready, good to go. The issue is if you then, that's you stuck. So if you want to stick with Ardens for for that reason, you can only use Ardens. You can't then add in your own rules on top. So it depends how your practice wants to play it.
Absolutely. It comes down to your choice in terms of your risk assessment and that kind of stuff. The other part is having that open and potentially challenging discussion in your practice about what you consider normal, what you consider abnormal, and what happens with all the computations in between as well. Because if you don't have a practice agreement as to how this is going to work, this is where it can get messy. So I do think you need to have that discussion within your team as to what does a good result look like. And there's going to be various different levels, obviously, depending on complexity. How have you found that process, David?
I have found it is humbling, because it's going down to the just because you can do something, should you do something? From that way. And so it's looking at, so for example, on one of my initial videos I did about TSH, and then I spoke to my next door neighbor, Dr. Nunnery, and I sort of said, like, I've done this TSH, so if it's normal, it goes away. And he said, what about thyroid cancers? I went, well, that's a good question. And he said, talk then about, well, what about pregnant people who have got these, that we need to have a look at them. And so I've disabled that rule. The other one as well is that I've done one for fit, so that if it's normal, so in our area it's less than 7, that it will auto file away. The issue is with us that our processes mean that if someone's not following up a fit, normally you would want to have a look at the notes just to make sure that they don't need even though with a negative result, they don't need a 2-week wait anyway. And so it's about your processes and how your practice works. And one that I was experimenting with is that our local labs have a very set, or our local radiology department, have a very set text. If a chest x-ray is normal, and I basically copied that, put it into a rule, and it works. But then we're all twitchy about, will it then not work if, for example, you get, chest X-ray normal, everything's clear, and then suddenly comment about incidental humeral head lesion or something that's just on the peripheries of the chest X-ray, and would it just auto-file it gone? So yeah, and thankfully we've got a good partnership that I can take these rules to and say, what do people think? And so I'll only activate them once we've got a group consensus of like, no, this is safe, I can see that. And actually it gives then, I think, as with anything techie, sometimes it's having the inspiration behind it in terms of what we can do or what people will find useful versus me just doing it for the sake of doing it. And actually that's where you need that group decision and group discussions.
And I think that also brings in one of the questions we had from one of our SystmOne Facebook user group users, EGP learner and stuff, about what is the audit process you use when coming through this kind of decision making. I know, David, you mentioned that you have a process whereby you get them signed off by 2 of the partners to make sure that the rules are accounted for, and there's a governance process within that. That sounds like a really positive way of doing things. I think my absolute advice to people would be you do need some sort of documentation to say that we've looked at this, we've assessed it, and this is what we agree is appropriate, because there is an element of risk. And with anything with risk, as we know, there needs to be a paper trail with it and stuff. Yeah.
And mine's just a very simple Word document that I've got, a very brief summary over the auto rules filing. And then I've got basically a large table that has the rule set underneath of like, we've agreed this rule. The one bit that and we've got agreed to discuss and declined. The one bit I do need to add is date of discussion, just so it's really clear when we've discussed it, who agrees with it, just in case anything were to happen, touch wood, it doesn't. And then take it from there, really.
Yeah. And I think from a governance point of view, I talk about this quite often, particularly with all the new tech coming through, especially AI and stuff, having that record of discussion is part of the thing that goes into all these stuff like your DPIAs and all the other kind of stuff that you should be doing that often people forget about. But in this situation, I think, absolutely reasonable to have just somewhere stored a document that says, this is what we're looking at, this is what we've agreed, this is why we think it works, and this is where we think it doesn't work and stuff. And having that consensus within the partnership, at the very least, the practice ideally, and figuring out where that safety net sits for you and your teams and stuff is a really important and things. I think you've got a template document that you're happy to share with everyone, haven't you, David?
Yeah, absolutely. I will, it's a very, very brief outline. Please feel free to sort of use it for your own it gives a rough idea of where I've gone with it. And all I've documented is the rules, any specific searches, because actually what you'll soon find is that your searches are really key to make this work well, which is something that they didn't quite sort of go into a lot of depth for. And then, but again, use it, please.
Definitely. So if you want to find out how to get to that, I will put that in the show notes below this YouTube video. If you don't know how to access that, this video will show you how. So subscribe, make sure you click all the notifications, as well as the notify me for the video. It'd be great if you could like it. Share it with your colleagues. And then if you want to see more details, click on more down below. And that shows you how to do it from both a desktop and, if you saw on the right hand side, a mobile device as well, if you want to get to that stuff. And both me and David stick loads of stuff in that show notes when you watch our videos and stuff. So do check there, because you'll often find handy little links and stuff and things to help you navigate stuff and things. So I would definitely recommend checking out David's stuff. But before we get to that point and show you how to get to it, one of the things I know people ask me about is, what can you actually do with this tool? So we're going to cover quick and easy wins. We're going to cover the middling ones, and then possibly the ones that you might need to work out. And even me and David haven't had a chance to go through yet, because they're that complex, but possibly really game changing if you figure them out. So where would you say is your quick wins, David?
Quick wins. I was going to say, do you want me to share my screen? I can show you.
Yeah, let's go for
my quick wins. Let's see if it'll let me work. All
right. So we're just going to share that now for you. There we go.
Fab. So we're on the auto review engine. To get to it, set up workflow support and pathology radiology auto reviews engine. Just bear in mind, before you even get to this step, you need to actually activate it within your area, and that's under your users and policies. and then the organizational preferences. Sorry, it's darting around all over the place. Organizational preferences, and if you look under pathology, it'll say about the auto review, or just search for it there.
Yeah.
Quick wins. Rattle through some quick wins that you need to set up almost now. ACR. So I'm just going to show you the ACR, and then if we amend the rule set, this makes life a lot simpler. So once you've got your printed out result, whatever it is, this is where I talked about the read code or the free text. So for us, the free text comes in as ACR, and you've got to make that exactly the same. Otherwise the rule doesn't work. I've just put it as title as ACR normal, because that's all I'm going to deal with from that way. So if we amend this rule set, it sort of goes into a bit more detail, because then it's the complexity of ACR normal, and then trigger if one of the following applies. Okay, so that's where it's useful if you've got a result where you're only looking at one specific value. Now, the value itself is then read coded. So you go into it and then you can amend it from that way, and you find the read code there with a little browsing the read code hierarchy, and then it gives you a list of things to do. Okay, so for this, it's a numeric range, and you can say it's between, less than. So I've done here less than 2.5, happy days, and then review not applicable, normal. So, and it just gives you a couple of options there. Okay, and just allows you to sort of, as you probably recognize all of these from your, from your usual pathology filing, and it's the same bits. So that's a really easy win. Likewise, using the same process for ALT. So if ALT is normal, the slight difference is here, it's a read coded. So even I put ALT normal, and this result, think about my federation work in the back of my head, I put NT for North T, so I know where I'm looking at it from. It's read coded event, and then you can just edit it from that way. And you can see here ALT normal, and that's the title of it. It's this read code, so the capital XA, capital L, capital JX, and it's got a value, and then going here between, and you've set your between 0 and 40. Okay, you could argue whether you just do it less than, but just shows you the options from that way. So they are your simple ones. Some slightly more complicated ones that I'm, probably screamed out and made everyone think I'm a bit weird than usual, is things like your GPC antibodies. So these took me to actually having to look at the text and look at the actual investigation itself. So they're free text investigation with a free text result, and it's got here. So if you go free text, and that's specifically what it comes out with when you hit present. Now it gives you a couple of options here, and it says textual result equals. You can do contains, but I think if it equals it, then it must have negative in. And I looked at a couple of results and it just says negative. So, and that works really nicely. But again, that's where going back to your homework of printing out the result and then take it from there. The one that was really annoying was the fecal occult bloods. So we get, even though an external, they're externally screened, we have nothing to do with the follow-up, nothing to do with the sort of the DNAs or the non-responders. We were still getting a couple of these results through. And this is an odd one where it's actually a read-coded investigation, but then a read-coded response. Okay, so I've just put normal and then specifically found that read code, and it works nicely. So I'm just like, and that's my nurse practitioner who normally follows this up, has given me a hug in the corridor, because I've saved her a lot of work in terms of, getting rid of them from that way. So they're the basics. I was going to go on to a couple more complex ones that sort of make you happy from that way. Now I need to activate this one, but here's BNP, for example. And what I love is searches, probably because I'm a bit sad. So if you're used to setting up searches, and there's normally someone in the practices, I've now got a bank of searches that are specifically for the auto filing, because you can then vary it in terms of your age. So for example, I've got a search which just looks at people over 75, and then I've adjusted the BNP value that if it's less than 250, that's happy. And that's come from our cardiology team, who've said, in the nicest possible way, we don't care. And, I haven't activated yet. I need to but it just shows you what you can do. And likewise, gone through their little flow chart and adjusted it for all the different age ranges. It's useful as well I've flirted around with HbA1c. So I need to tweak this one as well, because we've discussed it, that I've done it 2 rule sets. One is a not diabetic, you're on no medications for your diabetes whatsoever, no pre-diabetes, no gestational diabetes, and your result is effectively normal, then we'll clear it off. Okay. And I've done it as a result between 30 and 41. Admittedly, our lab's safe anywhere from 20 above, but I just wanted a bit of safety at the bottom end of this. Likewise, I've got a search that patients who are read-coded pre-diabetes, so they're having their annual review of bloods. If it's between 42 and 47, it just goes away and sort of sets it from there. So you can see here the search is pre-diabetes code exists, and then that's it done, and it will only apply to patients with that. One interesting bit that I need to sort of get my head around, that a good colleague of mine who works locally, is how often do you need to then run these searches, or does it automatically run in the background? So just at that risk of someone hopping off a search and then you suddenly accidentally autofile one away. But anyway, just food for thought. The other one,
can David, just to exemplify that one, so that particular search won't pick up patients who have diabetes who are now in the pre-diabetic range, because you've coded it to search for only patients coded with pre-diabetes. Is that correct?
Absolutely correct. So yeah, it will only be if they've just got a code of pre-diabetes, and then it will sort of pop up on a report from that way. So yeah, it's one of those that actually you raise a good point of whether, just thinking out loud, whether you've got patients who are coded pre-diabetic and then hop into the diabetic range, whether there should be a safety report that they're not on that as well. But that's where the combination exists from it. But again, that's where the discussion within your group needs to happen. Just thinking around all these different issues from that way.
And then I know you've got this lovely one about lipids. So show us that one.
Yeah, I've got effectively a search which just looks at non-HDL. Sorry, the auto rule just works on non-HDL, and if it's less than 2.5, and then I've got a search that if they're prescribed any lipid-lowering therapy, so all the statins, your inclisirands and ezetimibe, if they're documented that we've prescribed them or they're on their medical record, and your non-HDL is less than 2.5, it just codes it as normal, because effectively they fulfill that rule set. Now, obviously, I haven't got my head around, and we were discussing this beforehand, about the percentage drop and whether actually there is another group that we could get rid of. That's further work that I need to do, that I think Ardens have been able to get around it. But again, worth having a look.
And I guess if we're thinking about more complex ones to people to just try and sink their teeth into, I know we were talking about, could you do this for your PSA monitoring if you were doing that in practice, if you had a LES, for example, and stuff. Now, I think it is possible. There's a bit of work that needs doing, because you need to variably rate the level, because some patients will have different boundaries and things, and that's where it gets more complex. But I think you found a code that might help people with that one, didn't you?
Yeah, I was having a look at this, because I completely agree with you that with the PSA, you could do a simple one that, if they're similar as we did with the BNP, do an age stratified one to recognize the different rates. So that's the first bit. But then going with, I'm sure there's a read code that says PSA monitoring level or something to that extent. That if you then went to code all of them, because depending on your urology, they normally give you a target. So there wouldn't be any harm to then say, the code exists for, say, like less than 10, and then have that as a search, less than 8, less than 5, say, for example, and that if they exist on that search and have got a normal PSA, that it's sort of, I wouldn't put normal because legally it's not, but something like satisfactory. It's just something that, just those quick wins that you're not going to do anything with it, but it recognizes that you've put the thought and the work into it behind the scenes.
And I think this is absolutely where, as a practice, you need to be having those discussions, and you need to kind of work through this, because trying to do this independently is tricky, because we don't always know what you don't know. But also talking it through obviously helps that process. And as we mentioned earlier, that audit process of agreement that you need to have in terms of what you look at. I think there's real potential for this tool to help in practice. And David mentioned that already, how this is going to start to save time in practice. But this is still something you're going to need to do within your area, whether it's your practice, your PCN, or wider, to figure out where those comfort lines are, and also how this is going to work in your particular area. Now, for me, if I wanted to have a look at how to do this. To be honest, as David mentioned, his guides are absolutely awesome on this, so I would highly recommend checking them out. And if you want to do so, check out this video right here, which will take you to the playlist that shows you those 3 videos he's already done. And I'm pretty sure all the other ones he's going to add as he develops more of these, as we help you to tech enhance your primary care and learning. We'll catch you in the next episode.